Welcome to my presentation on facilitating complex birth with generalized anxiety disorder as a complexity of discussion. The facilitation of women experiencing generalized anxiety disorder (GAD) presents a significant and multifaceted challenge within the contemporary midwifery practice, as increasing numbers of women enter the childbearing continuum with pre-existing or pregnancy-induced maternal health complexity. There is a growing imperative to critically examine how such conditions intersect with physiological process, risk perception, and models of care. GAD, characterized by persistent and excessive anxiety, has the potential to influence not only maternal psychological well-being, but also physiological adaptation in pregnancy, labor, the postpartum period, as well as the newborn, thereby positioning it as a complexity that may disrupt the conventional understanding of normal childbearing. This presentation will critically explore the concept of complexity in relation to GAD and interrogate how deviation from perceived normality contributes to the construction of risks within maternity care. In doing so, it will examine competing perspectives within the literature regarding what constitutes a complex pregnancy and implication of categorizing women as risks, including the potential psychological and social consequence of such labeling. This discussion will be situated within broader debates surrounding normality in pregnancy and the extent at which risk is socially and professionally constructed. Furthermore, it will critically analyze the physiological and pathological dimension of GAD within the childbearing continuum, drawing on a range of literature to evaluate how anxiety-related mechanisms may alter maternal adaptation and outcome. Consideration will also be given to the wider determinants of health, including social, cultural, environmental, and systemic influences, and how they shape both women's experiences and provision of care. Finally, the role of the midwife in supporting women with GAD will be critically reflected upon, with particular attention to advocacy, individualized care, and the promotion of positive birth experiences within the constraint of current practice. Throughout this presentation, we will synthesize and critique a range of contemporary evidence to evaluate how care can be optimized for women with complex needs while challenging dominant narratives surrounding risks and normality in childbirth. Normal, understood as what is usual or expected. The term originated from the Latin word norma, meaning a measuring tool. This word has evolved into a medical and social standard word used to signal safety or acceptability. For midwives, defining normal childbirth is professionally significant, as midwifery identity is strongly aligned with supporting physiological birth. Traditionally, normal childbirth has been equated to spontaneous, intervention-free vaginal birth. However, advances in obstetric technology and increasing medicalization has blurred these boundaries, with some definitions now including vaginal birth involving interventions such as epidural anesthesia. Crucially, what is considered normal varies by culture and health system context. In many high-income countries, intervention-free birth is no longer common. With some settings, caesarean section is considered routine. Conversely, in part of sub-Saharan Africa like Ghana, Togo, vaginal birth is strongly associated with womanhood and social values, and caesarean section may carry stigma. For midwifery practice, this underscores the need to critically engage with the language of normality to ensure care remains woman-centered rather than norm-driven. Understanding normal childbirth, in addition to medical advice, is socially constructed and shaped by multiple influences, particularly media and social networks with interpersonal relationships. While it is debated whether media alone causes fear of childbirth, evidence shows that social media significantly shapes women's perception, especially of vaginal birth. Online narratives often present selective or negative birth stories that prioritize medicalized birth, undermine women's autonomy, and misrepresent physiological labor. These portrayals contribute to increased fear of childbirth, including tocophobia, which is characterized by anticipatory anxiety, psychological distress, and viewing birth as a medical emergency. In addition, Family and friends are a key source of information, particularly for nulliparous women, and misinformation within this network can further disrupt expectation. The definition of normal childbirth has evolved over time and remained contested within maternity care. The World Health Organization (WHO) 1996 initially defined normal childbirth as labor that begins spontaneously, remains low risk throughout, and results in a cephalic vaginal birth between 37 and 42 weeks without intervention, and mother and baby in good health. This definition positions normal childbirth as wholly physiological. However, WHO Intrapartum Care Guidelines 2018 reflect a significant conceptual shift. Rather than focusing on the term normal, the WHO now emphasizes uncomplicated birth and optimal maternal and neonatal outcome. While acknowledging that most women achieve favorable outcome through physiological labor, the guidelines incorporate certain medical interventions such as epidural anesthesia upon maternal request, uterotonus, and controlled contraction as acceptable elements of care. This evolution blurs the boundary between normal and medicalized birth and raises important questions about where normality ends. As Scott 2022 critically argues, at what point does intervention renders birth abnormal, and which intervention should remain compatible with the concept of normal birth? In contrast, the International Confederation of Midwife (ICM) has maintained a more traditional and philosophical grounded stand. In Keeping Birth Normal (ICM 2023), normal birth is described as a dynamic physiological process shaped by biological, psychological, and social factors. Labor is spontaneously initiated, processes without medication or surgical intervention, and ends in a vaginal cephalic birth at term. This definition reinforces midwifery commitment to safeguarding physiological birth. Similarly, other institutions across the world, like the midwifery organizations in the United States, as well as our RCM, that is the Royal College of Midwives, also have given their definition as adapted the term spontaneous vaginal birth in place of normal birth delivery after the rebirth report. It defines it as labor and birth that begins naturally without induction and progresses without the use of medical interventions such as oxytocin augmentation or instrumental assistance. In conclusion, definition of normal childbirth are not neutral. They shape data collection, clinical practice, professional identification, and women expectations. Understanding this definitional complexity is therefore essential for promoting respectful, evidence-based, and women-centered care. Complexity in childbirth, obstetric risks, and high-risk pregnancy are frequently used interchangeably, yet they remain imprecisely defined in the international literature. Holiness 2018. However, this conception has been recognized for several decades, with early acknowledgement dating back to 1970. Despite this long-standing recognition, there remains no universally acceptable definition of what constitutes a high-risk or complex pregnancy or childbirth. This lack of consensus continues to challenge clinical practice, research, and service planning. The World Health Organization in 2023 defined high-risk pregnancy as one that poses an actual or potential threat to the health or well-being of the mother and/or fetus, necessitating careful assessment and individualized care. Similarly, the National Institute of Child Health and Human Development 2018 described similarly but emphasized on the need of specialist input. However, this is not determined solely by pathology. Pearl and Zane 2023 argued that the designation of high risk is often shaped by contextual factors such as local resources, clinical expertise, and access to maternal fetal medicine subspecialists. The MSD Manual Professional Edition 2024 further broadens the concept of identified risks as rising from chronic illness, multiple gestation, previous obstetric complication, or conditions developing from the pregnancy. Population data suggests that approximately 1 in 5 women experience high-risk pregnancy complications, with non-communicable disease playing an increasing significant role in maternal and neonatal morbidity. Importantly, risk in pregnancy is not static. Pregnancy, initially classified as low risk, may evolve into high risk as new complications arise, reinforcing the need of ongoing and interactive assessment through pregnancy. Maternal fetal medicine specialists emphasize that high risk labels should not be interpreted as a prediction of poor outcome, but rather a classification of surveillance. Other food other food of thought have also said that when a woman is tagged as complex, it generates maternal anxiety, undermine confidence, and physiological birth, and contribute to unnecessary medication. A birthing person with existing maternal health disorder like GAD is of greater risk when labeled high risk pregnancy. Hence, the absence of standardized definition in high-risk pregnancy creates challenges for clinical consistency, audit and research, and limits meaningful comparison across healthcare systems. Although complexity in childbirth lack a universal definition, risk factors are broadly classified into two major categories: pre-existing factors and those that are arising from the pregnancy. They are further divided into social, demographic, and demographic conditions, medical condition, past obstetric history, and issues relating to mother and baby in the current pregnancy. Obstetric risk is multifactorial and extend beyond pathology alone. Key demographic factors include maternal age and extremes of reproduction, with advanced maternal age associated with increased risk of chromosomal abnormality, hypertensive disorders, and gestational diabetes. Parity also influences risks with non-parity linked to preeclampsia and prolonged labor, with gram multiparity associated with hemorrhage and placental complications. Abnormal BMI further elevates risk across pregnancy outcome. Social determinants including housing insecurity, risks, reduced access to quality maternal care, chronic stress, and structural racism are independently associated with adverse outcomes, including preterm labor and maternal mortality. A significant portion of high-risk pregnancy arises from pre-existing medical conditions like cardiac disease, diabetes, hypertension, chronic immune disorders, and mental illness, with cardiac disease being the leading cause of indirect maternal death. Risks further shaped by obstetric history, current pregnancy complication, and fetal factors, including congenital abnormalities. Most importantly, risk is dynamic and requires ongoing reassessment, reinforcing that high risk classification reflects surveillance need rather than inevitable poor outcome. Pregnancy and childbirth represent one of the most complex physiological and psychological transitions in human life. Despite major advances in biomedical risk surveillance, the psychological dimension of childbearing continuum remains significantly under-resourced, representing a structural failure with serious maternal and neonatal consequences. Wallace et al. 2022. The burden of perinatal mental health is substantial and rising. The WHO estimates that 1 in 5 women experience a mental health condition during pregnancy or the postpartum period, with prevalence marked higher in low-income settings. Global estimates vary widely from 5.6% to over 80%, reflecting the powerful influence of socio-economic vulnerability, stigma, conflict, and access to care. The variation signals not statistical inconsistency, but profound inequity in mental health risks and service provision. The situation is particularly acute in sub-Saharan Africa, where studies from Ghana report perinatal depression rate up to 50% and suicidal ideation of 13 to 17 in the context of minimal screening and limited service access. Ghana's introduction of a national maternal mental health policy in April 2026 represents progress, but also underscores decades of unmet need. Globally, fewer than 10% of affected women receive professional support, leaving most conditions undiagnosed and untreated. with significant intergenerational consequences. This highlights the urgent need to integrate mental health as a core component to maternity care rather than an adjunct. Anxiety exists on the continuum, beginning as a normal and adaptive response to perceived threat that supports coping vigilance. Stern and Sarin 2015. It typically presents a transient fear or nervousness proportionate to situational demands. However, when anxiety becomes excessive, persistent, and functionally impairing, it shifts from a normal response into a psychiatric disorder. Pullman et al. 2019. Anxiety is a multidimensional phenomenon affecting emotional state, cognitive behavior, and physiological functioning. In the perinatal period, anxiety is particularly prevalent, affecting approximately 15 to 20% of pregnant and postpartum women, and it is more common than perinatal depression. One key diagnostic category is generalized anxiety disorder (GAD), defined by persistent, uncontrollable worry across multiple life domains. American Psychiatric Association 2022. Women are diagnosed with GAD at roughly twice the rate of men, with prevalence peaking during the childbearing years. During pregnancy and up to 1 year postpartum, GAD prevalence ranges widely and comorbidity with depression is high, affecting up to 75% of women with postpartum anxiety. Despite this, GAD remains underdiagnosed in maternity care, particularly because symptoms such as fatigue, sleep disturbance, and muscle tension overlap with normal physiological changes of pregnancy. This highlights the need for improved recognition and integrated perinatal mental health screening. Before we discuss the pathophysiology of GAD on the birthing person, let us look at how normal pregnancy actually disrupts the physiology of the birthing person. It increases its blood chemistry, cardiovascular system is disrupted, the gastrointestinal system is disrupted, and there are general mood changes that occur in the birthing person before it is extra distracted by GAD. There are four main disruptions caused by GAD on the birthing person. In pregnancy, it causes chronic HPA axis dysregulation and sympathoadrenal activation, progressing to oxytocin suppression in labor and pain amplification and postpartum effect. This is further discussed in the next slide. On this slide, we'll discuss the pathophysiology of GAD on pregnancy. GAD consistently induces the HPA axis, resulting in elevated cortisol. In normal pregnancy, cortisol intensifies physiologically and enhances fetal lung maturation and the onset of labor. Nevertheless, pathological cortisol elevation interferes with this fine balance. The placenta secretes its own corticotropin-releasing hormone, which is then amplified by maternal cortisol to accelerate in secretion, creating a feed-forward loop that escalates the placental clock, increasing the risk of preterm birth, intrauterine growth restriction, and low birth weight. Elevated cortisol can diligently inhibit progesterone receptors and suppress its production. This is accompanied by premature cervical ripening and high risks of preterm labor as progesterone maintains uterine quiescence and cervical competence throughout pregnancy. GAD stimulates the sympathetic nervous system dominance continuously, secreting adrenaline and non-adrenaline. This catecholamine causes uterine artery vasoconstriction, reducing placental perfusion, chronically reducing blood flow, impair oxygen and nutritional function, consequently contributing to fetal growth restriction and small for age babies. Anxiety naturally increases during labor, which accelerates the level of catecholamine that inhibits oxytocin receptor sensitivity and disrupts uterine contraction. The love hormone oxytocin, secreted from the posterior pituitary, is the catalyst for uterine contraction, labor, placental delivery, and breastfeeding. Anxiety and its associated sympathetic activation suppresses the secretion of oxytocin from the posterior pituitary gland. They eventually can cause prolonged labor and increase the need of pharmacological augmentation, as well as difficulty in lactation postpartum. Anxiety-induced inflammation can interfere with normal balanced immune shift, Th1 or to Th2 during pregnancy. Anxiety is also known for its pro-inflammatory markers, including IL-6, which can disrupt the carefully regulated immune environment of the maternal-fetal interface during pregnancy. Perinatal GAD is not evenly distributed. It is fundamentally shaped by social inequalities. Latent class analysis of a diverse SafeNet population shows that 13 to 30% of perinatal mood and anxiety disorder profile involves multiple co-occurring social determinants, including poverty, interpersonal violence, housing instability, and food insecurity, Blable et al. 2024. This demonstrates that GAD cannot be understood or addressed through a purely biomedical lens. The consequences of untreated perinatal mental illness are substantial. It is associated with preterm birth, low birth weight, hemorrhage, placental abruption, and stillbirth. Suicide is still the leading cause of maternal death between 6 to 52 weeks postpartum, accounting for up to 20% of maternal death in high-income countries. The strongest upstream drivers are social determinants of health. Poverty is consistently associated with perinatal anxiety as material deprivation generates chronic stress and HPA axis dysregulation, increasing biological vulnerability. The urban stress model highlights how overcrowding, noise, and neighborhood violence disproportionately affect low-income women, while psychosocial risks accumulate across the life course, accompanying vulnerability at pregnancy. Socioeconomic disadvantage also limits access to recommended CBT due to barriers such as childcare, transport, and inflexible work despite NHS service expansion commitment. Systemic racism is another major determinant. In the UK, black women are nearly 3 times and Asian women twice as likely to die during childbirth as white women. Embrace UK 2024. Experiences of racism are independently associated with perinatal mental illness through stress, inflammation, and reduced social support. Qualitative evidence shows that culturally insensitive care and unconscious bias undermine trust, delay helping seeking, and worsening under detection of GAD. Social isolation, including migration, relationship breakdown, and intimate partner violence, further increase risks. COVID-19 clearly demonstrates how destructive social networks worsen perinatal mental health. Casavan et al. 2023. Housing insecurity, digital exclusion, and insecure employment add further structural stresses to perinatal GAD. In conclusion, perinatal GAD is produced and sustained by intersection, social, cultural, and political determinants. Effective response therefore requires integrated, equity-focused model of care rather than isolated clinical interventions alone. We will adopt a dual-track model of care in managing our clients to ensure safe delivery. This model is underpinned by 2 core principles. First, normal physiological processes are inherently protected. Labor characterized by endogenous oxytocin release, intact beta endorphin pain modulation, and parasympathetic predominance is associated with lower intervention rates, shorter labor, improved pain coping, and more positive birth experience. Supportive physiology is therefore a clinically active form of risk reduction. Secondly, effective management of GAD directly supports their physiological process. Psychological therapy, appropriate pharmacology, and supportive relational and environmental care reduces pathological stress response that otherwise disrupt oxytogenic and autonomic regulation. Treating GAD therefore simultaneously treats its obstetric sequence. This aligns with evidence linking poorly controlled perinatal mental illness to preterm birth, unplanned cesarean section, and maternal death. Antenatal serves as the foundation of care. Early screening using validated tools such as GAD7 and PASS, followed by collaborative care planning, ensures care is appropriate and woman-centered. Abrupt discontinuation of medication due to pregnancy alone is discouraged, as untreated anxiety often carries greater risk than continued therapy when appropriately assessed. NICE GC 192/2023. Psychological intervention, particularly CBT, are first line for mild to moderate GAD, with mindfulness-based and interpersonal therapies as useful agents. SSR or SNRI, most commonly sertraline, are indicated for moderate to severe GAD, while benzodiazepine are reserved for short-term crisis use. Supporting physiology antenatally includes midwife-led continuity of care, recommended by WHO 2018 and associated with reduced intervention and low postpartum anxiety. Surveillance should be framed as reassuring rather than risk signaling to avoid intragenic anxiety. Intrapartum protecting the oxytocin system is central. Calm environment, freedom of movement, hydrotherapy, and continuous labor support, particularly from a known midwife or doula, are strongly associated with improved outcome and reduced intervention. Boren et al. 2017 and WHO 2018. Epidural analgesia require nuisance collaborative decision-making given its beneficial and potential downstream effects. Postnatally, women with GAD are particularly vulnerable. Early skin-to-skin contact, breastfeeding support, continuity of care, and ongoing screening using GAD7 are essential. Breastfeeding is compatible with most SSRI, and discontinuation solely to avoid medication exposure is not recommended. In summary, supporting normal physiology and managing risks in women with GAD are not competing imperatives, but the same clinical goal viewed from complementary perspectives. Effective maternal care integrates physiological, psychological, and relational support across the childbearing continuum to ensure care remains safe, proportionate, woman-centered, and evidence-based. In caring for birthing people with GAD, the midwives must address six modified domains aligned with anxiety, neurobiological, and lived experiences. First is information and predictability. Intolerance of uncertainty is a core mechanism of anxiety, meaning individualized birth preparation functions as an active anxiolytic rather than a passive educational tool. Trauma-informed approaches further reduces triggers and enhance perceived control. 2. Trusted relational presence is critical. Continuous support from a known caregiver modulates the stress response through oxytocin-mediated pathway. Continuity of care should therefore be understood as a physiological intervention, not merely a service model. 3. Control and shared decision making are central. Loss of control is a primary predictor of negative birth experience. Genuine shared decision making restores agency and directly reduces stress related sympathetic activation. 4. An anxiety literate environment matters. Environmental factors such as lighting, mobility, familiarity, and structured communication reduce catecholamine load, positioning the clinical setting itself as a neurobiological intervention. 5. GAD regards a longitudinal care framework spanning antenatal, intrapartum, and postnatal phases. While continuity model faces critique, longitudinal relational care consistently demonstrates anxiety reducing effect. And finally, respectful, non-stigmatizing care is essential. Stigma and dismissive attitude generate iatrogenic anxiety, undermining safety and outcome. Respect is therefore both an ethical and clinical necessity. Midwives occupy a uniquely influential position in maternity care due to our sustained relational and clinical proximity to the birthing people. As the Royal College of Midwives 2024 highlights, midwives spend more face-to-face time with women across the childbearing continuum than any other healthcare professional. This position acts as essential to identifying perinatal guard, building therapeutic alliance, coordinating multidisciplinary care, and challenging unsafe or inequitable practice. However, evidence suggests that while this potential exists, midwives are only partially equipped and institutionally supported to realize it fully. Advocacy is the core professional obligation in midwifery, embedded within the UK NMC 2028 and the ICM Essential Competency 2024 and across other country codes for NMC. In the context of perinatal guide, advocacy operates at three levels: individually by protecting autonomy and informed consent, professionally through maintaining standard and escalation, and systematically by contributing to education, policy, and service redesign. The specialist perinatal mental health midwife role, evaluated across Scotland, demonstrates how advocacy at all levels can significantly improve women's experiences and continuity of care. Advocacy is also a relational and clinical act. Evidence from HealthWatch UK 2023 shows that lack of continuity of care places the burden of self-advocacy on women, which is particularly harmful for those with anxiety. Securing continuity therefore functions simultaneously as therapeutic intervention, a clinical necessity, and a structural demand. Active listening, validation, and anxiety-sensitive communication are not optional soft skills for midwife, but evidence-based clinical practice mandated by protocol. Beyond individualized care, the midwife is positioned as an agent of system-level change. National data from Embrace UK identify maternal health conditions, including suicide, as leading cause of indirect maternal death alongside persistent racial and socio-economic disparity. These findings make clear that individual clinical excellence is insufficient without structural reform in education, workforce capacity, and service design. The paper highlights a significant education and confidence gap, with studies demonstrating limited midwifery knowledge of perinatal mental health, particularly anxiety disorders. The RCM Perinatal Mental Health Roadmap 2023 responds by calling for specialist role, curriculum reform, and cultural changes while warning that support remains critically under-resourced. Ethically, the midwife advocacy role is framed through principles ethic and feminist bioethics, emphasizing autonomy, beneficence, non-maleficence, justice, and attention to power imbalance. Legal frameworks including Montgomery versus Lenaskal 2015 and Mental Capacity Act 2025 reinforces the duty to protect informed, non-coercive decision making, even amidst institution pressure. In a nutshell, the midwife's role in perinatal guard extends far beyond detection and referral. It comprises relational care, protection of autonomy, multidisciplinary coordination, education, quality improvement, and systemic advocacy. When these domains are integrated, the midwife becomes one of the most powerful factors available to birthing people with GAD. Conclusion: perinatal generalized anxiety disorder disrupts physiological and emotional birth process, affecting oxytocin release, labor progress, and maternal-infant bonding. Care must be integrated, person-centered, and trauma-informed. Midwives are pivotal advocates, ethical leaders, and agents of change. Supporting normal physiological means supporting the whole person. mind, body, and context. Thank you for listening to my presentation. From these slides are my references.